Stroke. We continue our discussion. Now in this lecture I'll be talking to you regarding lacunar stroke syndrome. Well, first of all, let me tell you, lacunar stroke syndrome are always due to ischemia. Okay. Well, before I discuss lacunar syndrome, let's learn some basic concept. What are these? What is a lacune? Lacune is a small cavity, and the size of cavity is less than 1.5 centimeter. Okay, and this remains. It's remaining in the brain tissue that develops. But I told you that this lacunar and stroke occur due to ischemia. So the ischemia lead to necrotic tissue, necrosis of the brain, and scavenger cells. Let's say this is the normal brain, and here is the infarct tissues, and it's dead. In a due course of time, scavenger cell, they will remove this dead tissue, and once they remove that tissue, ultimately, let's say this is gone. Now this open area will remain. That a small cavity will remain. That's what we call as lacune. Okay. So now this infarction occurs in deep tissues, deep brain tissues. What are the tissues? I'll discuss soon. That's why they are always found in the deeper layer of the brain. And I remember, this lacune all typically follows lacunar stroke, which is, as I told you, is always a ischemic stroke. So in nutshell, removal of dead tissue after the ischemic stroke is lacune will produce. Now it results due to blockage of deep blood flow, I told you just now, of small penetrating vessels. Now what is the meaning of small vessel? These vessels are usually of the size 0.3 to 3 millimeter size, deep, and they are deep penetrating tissue, and they supply mainly the subcortical white matter region, and that is basal ganglia, internal capsule, corona radiata, thalamus, or the paramedian pons. All these I'll be talking to you in great details. And remember, that's why as the small vessels are involved, lacunar strokes are also known as small vessels disease. Well, now what are the blood vessels which are responsible for all these things? First is lenticulostriate artery. I'll be showing you the photograph in the next slide, but at the moment just write down. Lenticulostriate artery is the branch of middle cerebral artery. Geniculate arteries, the branch of posterior cerebral artery. And paramedian branches, they are the branches of perforator of basilar artery. Now what is pathogenesis? Why this happen? Main reason is hypertension. So that lead to lipohyalinosis. That means that lead to arteriolar sclerosis. This lead to sclerosis. And second is formation of microthrombi. So both these, due to lipohyalinosis and microthrombi, it will lead to ischemia, and ultimately it lead to necrosis, and ultimately, as I told you, this necrosed tissue will be removed and that will produce lacuna, and that's the reason why we get lacunar infarct there. Now the arteries I was just show you, so let me show you a photograph also. Lovely photograph, lenticular branches of MCA I told you just now, and these are the lenticular arteries. Then thalamo-genicular artery of PCA, these are the, and finally we get paramedian perforator, they are from basilar artery. Okay, now I hope picture is much clearer to you. Now common areas where lacunar infarct occurs, that you should know. Okay, again areas I have shown you lovely with the arrows. Lacunar infarct is there. Well, one more thing, what you must have noticed, some of these areas which I talked to you regarding, they are also the site of hypertensive bleed. Right? I hope. What are the common sites of hypertensive bleed? Of course, the site of bleed are hypertensive bleed. Extra knowledge for you. It is in basal ganglia, especially the putamen. Second is cerebellum. Third is pons. Fourth is thalamus. And the fifth one is parenchyma, brain parenchyma. Okay, so now you can see there are many common features. We have a hypertensive bleed and a lacunar stroke, about which I am going to talk soon. But out of all these hypertensive bleed, this is the most common, parenchyma. But if I leave aside parenchyma, then out of all these four, putamen is the most common. And pons is the one which has got 100% mortality. And all the hypertensive bleed, I have recorded a separate lecture, you can see in that. But at the moment, we got extra knowledge that there are some common sites of lacunar infarct and hypertensive bleed. And remember, even lacunar infarct, the main pathophysiology is due to hypertension. This is what I want to convey the message to you. Well, most of the time, lacunes are made, are formed, but they are no symptom at all. Okay, but that means presence of lacune is not always known that patient will have some problem, maybe asymptomatic. Why asymptomatic? I'll discuss very shortly, because at places we have double blood supply also. That's why even if one side of blocked, other side can take care of the ischemia part. But because lacunae are very, very small, remember the size is 0.3. It may be it is less than 1.5 centimeters. It's never a big lacuna, and the arterial supply size is 0.3 to 3 millimeters. Suppose a 0.3 millimeter artery is blocked. Is too minor a artery to block, so patient may have some ischemia, maybe lacune also, but patient doesn't develop much of the symptom because of size. So as I told you, most of the lacuna are asymptomatic. Otherwise, patient present with classical lacunar syndrome, and you can get image reveal evidence of some ischemia. As I have just shown you the pictures, CT scan is very sensitive. CT scan is not very sensitive to pick up this, but MRI with diffusion weighted image is far better diagnostic tool, because it is always the modality of choice. Now I'd like to show you some of the lacunes. Remember, this we can see in MRI, CT scan usually misses this small infarct. Now I'll talk to you regarding various lacunar syndrome. First is the pure motor hemiparesis. That means patient has only motor symptom. sensory system is not there, no sensory loss. And it is the most common type of Lacunar syndrome. It is seen in around 33 to 50% cases of the lacunar stroke. Now, it usually involves the posterior limb of the internal capsule. It may also involve corona radiata, it may also involve the basis pontis, but usual site is posterior limb of internal capsule. Now, let me explain to you why this is happening. This you will never understand unless you know the basic anatomy. So, from the basic anatomy we learn why we have only motor involvement. So, let us learn the basic anatomy of the internal capsule. This is the internal capsule. This is the anterior limb, this is the posterior limb, and I am sure you know about the location of fibers. In the posterior limb, in the anterior part, we have a motor fibers, corticospinal tract which is going down. Here we have a sensory fibers which are going up, right? Well, there are many other features also, but at the moment I will confine to these two only because this is relevant to my talk at the moment. And I told you these areas are supplied by deep small vessel. We got one vessel which supply the motor, and we got one which supply the sensory fibers. So, if this artery, the small vessel which is supplying only the motor fibers, the patient will have pure motor hemiparesis. Similarly, if this vessel is involved, it is going to have pure sensory manifestation about which I am going to talk soon. So, now you understood why patient will come with only pure motor hemiparesis. Now, one thing more, just here lies the basal ganglia, and a couple of minutes back I told you hypertensive bleed occurs in basal ganglia, and the basal ganglia bleeding occurs, but patient manifests as hemiplegia. How can we explain to you? So, bleeding occurs in basal ganglia, putamen to be more precise, and this blood, because they are very closely packed fiber. Here I have shown you a very large diagram. In actual practice they are very close packed fiber. This bleeding will spread into motor and into this area. That is why a patient of basal ganglia will manifest as hemiplegia with usually loss of both motor and of course sensory feature, because bleeding may involve motor and sensory. And in due course of time the patient may recover fully. Why? Blood is there, scavenger cell, they remove the blood, and that is why function of both motor and sensory revives again and patient recovers fully. But at the moment you understood why you get pure motor hemiparesis in lacunar stroke. And as I told you, there is no sensory deficit, reason I told you. And one more thing, there is no cortical finding. Remember, in any lacunar stroke, no cortical findings. That means that include cortical finding include aphasia, no aphasia, visual field abnormalities are not seen. They are not seen. So, in nutshell, no cortical findings, about which I'll talk a little later on again, they are not there. Dysarthria may be there, but this is due to secondary to some, maybe some, not as such occur due to involvement of muscles, but some because of hemiplegia patient may have some difficulty in speaking, but it as such dysarthria occur more commonly when bulbar involvement is there. Now, second type is pure sensory. stroke, pure sensory stroke. This I explained to you when the sensory fibers are involved, and this infarction usually involve thalamus. But of course, it may involve if the internal capsule is sensory fiber, but more likely in actual clinical practice, more likely to seen in thalamus. Why? Again, the basic concept. You know, this is a thalamus of right side. So ultimately, posterior column, this is left sided posterior column, which contain position and vibration sense. It goes to other side, come to thalamus. Okay. Similarly, pain, touch, temperature, they enter the cord. They relay on same side. Pain, touch, temperature. Second order neuron, they cross to other side and they come to thalamus. Ultimately, position, vibration, pain, touch, temperature, all sensation from contralateral body, they come to the thalamus. So left sided, all sensation are coming to right side, and if the stroke occurs here, there will be complete hemi-anesthesia on the contralateral body. Of course, same thing can happen in internal capsule lesion, especially in the posterior limb, but in actual practice it's more commonly seen in thalamic stroke. I think you have understood the basic concept. So, all sensation are lost, as I explained to you. Okay? And this is usually, what else is there? Patient may have complaint of some pins and needles type of sensation, feeling can be there, because again due to sensory involvement, but again no cortical finding. This I am repeating for the second time. This is why it is so important that normally whenever we have massive involvement of big artery, cortical sensory are lost. Now sensory motor, here there is loss of both motor and sensory, both are involved, and this is usually seen in patient. At time patient may have involvement of both internal capsule and thalamus. If the combined problem is there, then patient may have motor and sensory, and patient have, as I told you, there will be contralateral hemiplegia, and there will be contralateral loss of sensation loss also. It's in nutshell, it's a combination of what we discussed previous two stroke, motor stroke and sensory stroke. Again, here also there is no cortical loss of sensation. The next is ataxic hemiparesis. This is due to, again, involve internal capsule or corona radiata or pons. In this, patient has contralateral hemiparesis plus there is contralateral ataxia also. So patient has ataxic feature in addition to hemiplegia, we call as ataxic hemiparesis type of lacunar stroke. Then we have dysarthria, clumsy hand syndrome. This is usually it involves pons and internal capsule. And patient typically present with dysarthria. Dysphagia, contralateral facial paresis, and there may be tongue paralysis. Okay, tongue weakness, and there may be contralateral hemiparesis or clumsiness of the arm and hand also. Okay, this what is the dysarthria, clumsiness and hand syndrome. But in all the stroke, lacunar stroke, cortical signs, what are the cortical signs that I have been talking to you? Aphasia. Aphasia is due to involvement of Broca's area and Wernicke area. They are supplied by middle cerebral artery. So they are involved when there is involvement of big artery like MCA. Aphasia is not a feature of Lechner stroke. Agnosia, this occurs when the parietal lobe is involved. Parietal lobe is again supplied by MCA. Again, it is not seen in Lechner stroke. Neglect, apraxia, again seen in MCA infarct, in the involvement in the parietal lobe, not seen. And hemianopias are usually seen when there is involvement of big artery like posterior cerebral artery. This is again not seen in cortic Lechner infarct. Seizures are not a feature. And mental state changes, that is altered sensorium, is not a feature. Why not? Because now why altered sensorium occurs? Usually in a stroke, the cause of, there are many things, but I'll talk two broad things which are relevant to stroke, which lead to altered sensorium. One is increased intracranial pressure. This especially occurs in bleeds. And second is cerebral edema. Cerebral edema directly increases raised ICP, and that lead to altered sensorium. Okay. So these things, that means the cerebral edema is not a feature. This typically occurs in both ischemic stroke as well as hemorrhagic stroke. So in Lechner stroke, ischemia is there, raised cerebral edema is not a feature, and that's why altered sensorium is not a feature. So that means you are getting a patient with stroke, patient has seizure or altered mental status, pakka is sure that you are not dealing with Lechner stroke. Now how you can prevent Lechner stroke? You have to do aggressive risk factor modification. That means you have to control hypertension, which is the most important risk factor for developing ischemic stroke. Of course, in addition to that, you have to control diabetes, stop smoking, okay, and dyslipidemia, lipid has to be controlled. All other risk factors for atherosclerosis, ischemic stroke should be. We can give antiplatelet therapy with low dose of aspirin. It is a really good preventive method. Now, as I talked to you regarding the various risk factors just now, but remember, out of the four, that is hypertension, smoking, lipid, and diabetes, hypertension is the most important risk factor. And of course, age is also a problem. This is a problem, the aging. It's usually not a problem in young person. That means suppose a patient of 25 or 30 years come to you with stroke, Lechner stroke, then perhaps we are not correct, because it's usually this problem occurs in the elderly people, not in the young people. Okay. And of course, as I talked to you, other risk factors like diabetes, smoking, and hypertension, okay, and dyslipidemia has to be controlled. So a quick recap of Lechner stroke, what we learned in this lecture. So etiology of Lechner stroke is small penetrating artery occlusion, and that's why this is also known as small vessel disease. The usual area involved are basal ganglia, subcortical white matter, internal capsule, corona radiata, pons. And the risk factors are hypertension, diabetes, smoking, and hyperlipidemia. And this is the most important. And other is, of course, age is also a problem. The clinical syndrome that we see are pure motor, this is the most common, pure sensory or both sensory motor, ataxic hemiparesis or dysarthria, clumsiness, hand. And what are the things which are not seen in stroke, Lechner stroke? Cortical signs like aphasia, agnosia, neglect, apraxia, and hemianopia are not seen. Seizure is not a feature, and altered sensorium is not a feature. Thank you very much for watching this video.